Yes, I don't know what Bhushan did just now, but he kicked me out of the meeting. So hopefully I'll be able to share on this new link. Okay, so is that visible now?
Yes, sir.
Okay, so we'll go ahead. So the first thing we need to know when we talk of cerebral palsy, of course, is spasticity. It doesn't mean that every child with CP has spasticity, but the majority of them do, because we know that it's an upper motor neuron lesion. So I think we should be aware that when we define spasticity, it's an increase in the muscle tone because of a hyperexcitability of the stretch reflex, and is typically characterized by a velocity dependent increase resistance to passive stretch. So this is the classical definition of spasticity. So when we see a child with CP, the first thing that we need to do is to find out what is the motor type. So there are various ways we classify children with cerebral palsy. One is by the topography, but the first step is to look at what the motor type is. And we define motor type as either being of the spastic variety, dyskinetic, which can either be chorioathetoid or dystonic. You could be hypotonic with an ataxic variety or a mixed pattern. And for many years, we believed that spastic cerebral palsy was the most common motor type. But we know now, in fact, that most children present with a mixed pattern where you have predominantly spasticity but some dystonia, or some children who have predominantly dystonia but some spasticity. So these true types of either pure spasticity or pure dyskinesia is quite uncommon, I think, in today's day and age. And of course, seeing a child with very severe dystonia is, we occasionally see them, but not as common as we used to do before, when we used to have many children who used to have hyperbilirubinemia and therefore kernicterus and developing extrapyramidal signs of dyskinesia. So, though we do see dystonia, many of them have a combination of spasticity with dystonia. So, here's a child, if you can see the gait pattern, this is a child typically with spasticity, how they tend to walk. And I'm not saying that we are going to classify the motor pattern just based upon a gait analysis, but if you see a child walking with a fairly consistent gait pattern, as in this child, you can see that she is either an asymmetric diplegic or a hemiplegic, and every gait cycle is consistent. And this is usually the feature of what we see in spasticity. Whereas if you see a child with dystonia, they have these very typical writhing movements, and every gait cycle looks a little different from the other one. So this is how a child with dystonia generally will present. You can see that these very large involuntary movements of the limbs and very typical posturing of the upper and lower limbs, which is not generally seen in um, spasticity. And then occasionally you'll see a child who has ataxia, and typically this is how their gait is. They have a broad based gait, their arms are spread across so that they can get more balance. And this is how sometimes you can diagnose a child who has vestibuloproprioceptive ataxia. So these are just the different gait types and the motor patterns that you see in children with cerebral palsy. And that's why we always say that when we check a child with CP, we examine them from the time they start walking towards and away from you in the clinic before you put them down on the couch to actually examine them. So from the gait itself, from a visual analysis, come to a fairly good conclusion. What motor type are we dealing with? Is it predominantly spasticity? Is it predominantly dystonia? Is it ataxia, or a combination of all these findings? So the next thing that we look at, of course, is the topography. And the topography, once you know the motor type, we're trying to see what body part is involved in these children. Is it more hemiplegia, where we know that both just one side of the body is affected? Generally, the upper limbs are affected more than the lower ones. Is it diplegia, where you have uh, all four limbs affected, but the lower limbs affected more than the upper one? And sometimes you can have children who have asymmetric diplegia, which is something we should not miss because they look like a hemiplegic pattern. But when you examine them closely, one side has very predominant findings, but the other side also has some subtle findings. So whenever you see a child with hemiplegia, check the other limb carefully to be absolutely sure that it's normal before labeling them as hemiplegia, because many of these children have asymmetric diplegia, where they have inconsistent patterns, one side more severe than the other side. And then, of course, we have quadriplegia, but quadriplegia does disservice to the actual terminology because when we say this quadriplegia, we only indicate four limbs involved, but these children have far more than just four limb involvement. They have a lot of truncal issues as well. They have a lot of other comorbidities. They have feeding issues. They have nutritional problems. They are much more severely affected than just putting them as quadriplegia. So maybe we should find a better terminology for these children. But as of now, this is what we call them: hemi, di, or quadriplegia. So again, I'm not saying that by the gait pattern itself you can come to a diagnosis, but reasonably so that if you see a child who has predominantly one side of the body involved, as in this child, you can see that the left side of the body, the upper limb and the lower limb are definitely. So this is how typically you'll have a gait pattern in a child with hemiplegia. And then if you see a child with diplegia, this is generally their gait patterns, that they have both lower limbs involved more than the upper limbs, but they also have truncal involvement. Here you can see that this is a child who walks in what we call jump gait with hip, knee flexion, ankle in equinus. Look at the pelvis also, that there's lack of truncopelvic dissociation, and there is a lot of posterior tilt of the pelvis as well. So just from a visual gait analysis, there's a lot of information that we can get from examining children with cerebral motor type, what is the likely uh, topography that we're dealing with as well. So to go in further, looking at the gait patterns, once we know the topography and the motor type, we can then classify them further. And I think all of you all are aware of this, that once you know that the child has got hemiplegia or diplegia, you can classify them further. And that is helpful because it guides our treatment. It guides our conversation that we have with the physiotherapist as well. So one of the earliest classifications in terms of hemiplegic palsy was the one by Winters and Gage. And this is based on the sagittal gait patterns mainly. And there are four types in this, and we'll talk about each of them in a little more detail. So if you look at the Winters and Gage type 1, this is typically what we call a drop foot gait pattern. And this is most evident in the swing phase. And during stance, they're usually normal. Here, the problem with the pathology is in the weakness of the tibialis anterior. They don't generally have any calf contracture. And the reason why this is important is because when you look at the treatment point of view, you just have to support them in swing. They are quite stable in stance. And all you need sometimes is a flexible AFO, which we call a leaf spring AFO, which basically supports the foot in swing, so allows the foot to clear the ground. And in stance, it allows all the three ankle rockers to occur. I'm sure you'll have discussed about the three ankle rockers, and maintaining the three ankle rockers in stance is very crucial for children with cerebral palsy. So children who have a type 1 hemiplegic gait, where there's just a foot drop, you don't need to really limit their ankle rockers. So a leaf spring AFO, which is flexible, allows them to have all the three ankle rockers in stance and also support them to clear the ground and swing. So here's a child who has a type 1 hemiplegia. It's a very subtle sign, and unless you really use slow motion analysis, you'll not be able to pick up. So on the left side, you can see that there is a bit of the toe drag. Look at the right side, how easily she's lifting off the foot from the ground. But on the left side, you find that there is a bit of drag or a slow tibialis anterior activity. And when you look at the kinematics of the ankle, this is what you will see, that the knee, hip, and the pelvis look fine. The ankle in stance looks fine. All the three ankle rockers are present. But in swing, the foot is not able to dorsiflex and it remains in plantar flexion throughout the swing phase. So this is how the 3D analysis would look like. If you move to the next type, which is the true equinus, now in addition to the foot drop in swing, they also have a contracture or a spasticity of plantar flexion and true equinus during the stance phase. And here they actually have a contracture of the gastrosoleus combined with a impaired ankle dorsiflexors. So if you see a child with type 2, you can see that here what is manifest. So in the ankle, you'll see that in the graph charts, this is the new line. Normally, the ankle should be in dorsiflexion, but you can see here that the ankle is in plantar flexion throughout the gait cycle in both stance and swing. And the knee may also show some changes because you can see here in this video that though there is not really toe walking, you can see that there's recurvatum of the knee. And this is the same phenomenon basically. When you see a knee recurvatum, what it indicates is that there is a tight gastrosoleus. And this is what we call an overactive plantar flexion knee extension couple, where because you have the tightness or spasticity of the soleus, rather than the child toe walking, the soleus is pulling the tibia backwards, causing the center of gravity to move in front of the knee. And therefore, back kneeing or a knee recurvatum is another sign of a tight gastrosoleus complex. So this is how a type 2 gait pattern would manifest. If you look at the third type, now you're moving up from the ankle towards the knee, and a type 3 hemiplegic gait has a combination of true equinus along with a jump knee. And the knee can either be just flexed throughout stance, or it can be a stiff knee gait, where we know that in swing, the knee should flex at least 60 degrees to be able to clear the ground. But if you have a stiff knee gait, not only does the knee remain flexed in stance phase, especially during the mid stance when actually the knee should be extending. If you know the kinematics of the knee in stance, there's a double knee lock, one which happens in the initial contact and the second which happens in mid stance. And if you don't have a knee which can extend in mid stance, then that destabilizes the body and the knee remains flexed. Furthermore, in swing, if you don't have a peak knee flexion of at least 60 degrees, then that's again a stiff knee gait, which will again cause a problem with ground clearance and that you have a shorter step length. So this is how you'll have a type 3 gait. So a type 3 hemiplegic, really you'll see that there are abnormalities in the ankle, the knee, and the hip, where you can see here that on the right side, the heel is off the ground. There is a recurvatum of the knee, and there is also a stiff swing. You can see that there's a short step length on the right side. The child is not able to clear the ground, and there's a shorter step length on that side as well. So here you have abnormalities in the ankle and the knee. And then you have finally the type 4, where in addition to the sagittal gait pattern, the abnormality also extends up to the hip. And in addition to the equinus and the flex stiff knee, you also have an anterior pelvic tilt with hip adduction, internal rotation. So this is manifested not only in the sagittal plane, but also in the coronal plane. And that's how a child with a type 4 hemiplegia would typically walk, where you can see abnormalities in the ankle, the knee, and the hip. So if you see this left side, you can see that the heel is in equinus. The ankle rockers are affected throughout the stance phase. The knee is stiff and flexed, and also there's adduction and internal rotation present at the hip. So this is a type 4 gait pattern. So these are the 4 gait patterns in hemiplegia. For many years, people try to classify diplegia on similar lines as well. And David Sutherland and John Davids came out with a classification in diplegia, basically just focusing on the sagittal kinematics of the knee in diplegics, classifying them as jump knee, crouch, stiff, or a recurvatum knee. But this was not very satisfactory because it didn't take into account what's happening with the kinematics of the ankle and the hip. And then in 2001, Jill Roda and Kerr Graham came out with the classification that we now use for diplegia, which is based upon, again, the sagittal gait patterns, classifying them as true equinus, jump, apparent equinus, and crouch. So these are the 4 different gait patterns that they have. And what we have seen is that we feel that these type 1 to type 4 are not sort of discrete type gait patterns, but they're actually a spectrum of continuum, where as the muscle involvement goes from more distal to proximal, the compensatory mechanisms become less effective, and many of these children progress from a type 1 into a type 4 gait. So rather than having as discrete types, I think we now believe that this is a continuum, where when they're young, they present with a type 1 diplegia, where they have toe walking. And then as they grow older, they transition from a toe walking to a jump knee to apparent equinus and then finally to crouch. And by doing inadvertent gastrosoleus surgeries on these children when they're younger, can push them into a crouch gait earlier rather than what they are naturally, by natural history, supposed to do. So a type 1, just like in a type 1 hemiplegia, manifests with a true, it's more like a type 2 of hemiplegia is like what a type 1 diplegia is, where there's true equinus, where the ankle remains in plantar flexion throughout stance and swing. And again, this is how a child with diplegia of type 1, where there's true equinus generally present. So you can see that they are walking on their toes all the time. And also in stance, in mid stance, the knee is going into recobatum because again, you have an overactive plantar flexion knee extension. The soleus pulling the tibia back in mid stance, the center of gravity moving in front of the knee, and therefore the knee getting locked in extension. So this is how a type 1 diplegia usually presents. Type 2 is more proximal involvement now. So in addition to the equinus, you also have a jump knee gait. And just like in hemiplegia, we said that the hip and knee remain in flexion with the equinus, and you can have either anterior pelvic tilt with increased lumbar lordosis, or the hamstrings are really tight, you can get a posterior pelvic tilt and loss of truncopelvic dissociation. So these are children how they normally walk with a jump gait, and you can see like bouncing dolls because of the flexion at the hip, knee, and the dorsiflex and the equinus at the ankle. This is how they generally tend to walk. Or you can have a child who's much slower as they grow older, but again, a manifestation, and this is the child I showed you earlier again as well, where in addition to the stiff knee gait, the ankle and equinus, here rather than increased lumbar lordosis, there's in fact a reduced lumbar lordosis because of a posterior pelvic tilt, indicates that the hamstrings are really tight in this child. A type 3 is more difficult to pick up, and this is as we move along the continuum from true equinus and jump knee as they move towards crouch, they tend to develop what's called an apparent equinus, and this is very subtle. Here it looks as if the heel is off the floor, but if you look at the angle between the tibia and the foot in stance, there's actually a 90 degrees angle. So whatever heel is off the floor is not coming because of gastrosoleus spasticity or contracture, but rather coming from hip and knee flexion, which is causing the heel to come off the floor. So in fact, here the calf muscles are quite weak, and you can see that increasingly what is happening, that very overactive plantar flexion knee extension couple is now transitioning to an incompetent plantar flexion knee extension couple because these children are now getting weaker as they grow bigger, and the muscles are now unable to maintain their anti-gravity stance. So again, this is a subtle sign. It looks like as if it's a jump gait, but if you see the angle between the tibia and the foot in stance, it's a 90-degree angle. So the flexion, the lifting up of the heel is not coming from the gastrosoleus, but it's coming because of hip and knee flexion. And this again is how a child with a type 3 gait pattern tends to walk. You can see again here on the sagittal plane that heel is off the floor. It's not a problem with the gastrosoleus. It's because of the hip and knee flexion that's actually driving the heel to come off the floor. And this is the apparent equine. And of course, we go to the most deleterious of all the gaits, which is the crouch gait, where you have ankle dorsiflexion, a worsening gait pattern, and combined with an excessive hip and knee flexion. And the reason why this is so pernicious is because you can see from the stick figure that unlike in the normal gait, where the center of gravity passes through the center of the hip and the knee, in a crouch gait, it's going way behind the center of the knee and way in front of the hip. And therefore, the extensors, which are the vasti and the gluteus maximus, which are supposed to be just power generators, they're not supposed to work throughout the gait cycle. They're only on in the initial phase of gait, have to work throughout the gait cycle to keep the body propped up. And this is what causes the severe inefficiency of gait, a high degree of power consumption, and why it becomes so difficult for these children to walk as they grow older. So this is all about the biomechanics of gait, where you can see the red muscles, green muscles are the power generators, and the red ones here should just switch on only in the initial phase of gait. But because the center of gravity is moved behind the knee and in front of the hip because of crouch, the vasti and the Gmax need to work throughout the gait cycle, which causes a lot of fatigue for these children and a lot of power consumption. So this is what we know about crouch gait. It's usually precipitated by the adolescent growth spurt. Most of these children have a pre-existing lever arm disease, which is a combination of increased femoral anteversion, external tibial torsion, and planovalgus foot. And they have weak soli, which is usually pushed by an iatrogenic lengthening of the gastrosoleus in children with diplegia. And that's why we always say that in children with diplegia, think a lot before you do any sort of gastrosoleus lengthening. Even a simple strayer can cause a lot of weakness of the gastrosoleus and push these children towards the crouch gait. And the biomechanics behind this, as I've explained, is that you have excessive ankle dorsiflexion, the second ankle rocker, because the ground reaction force has moved behind the knee and in front of the hip, and an incompetent plantar flexion knee extension coupled with continuous firing of the vasti and the Gmax, which cause a very energy inefficient gait and a lot of energy consumption. So with these elements of the gait patterns that we can identify in diplegia and hemiplegia, it's good to understand the role of gait analysis in these children. And there are different ways we can do gait analysis. The easiest way is to just do a video shooting of these children. But remember that many of the events in gait last for less than 1/60th of a second, and the human eye cannot frame that. Not 1/60th, but 1/16th of a second, which the human eye cannot frame. And therefore, if you want to do a gait analysis by video, you need to have a slow motion gait analysis. So you really use a slow motion video in the sagittal and the coronal planes, and then you can actually stop the frame, freeze frame it, and look at the gait analysis in different aspects of the gait cycle, which I'm sure you must have already discussed in the previous lectures this month. But we know that by understanding gait in CP, we understand what type of pathological gait these children have. We can then do a more rational prescription of the various orthoses that we're using for these children. We can target which muscles will benefit with botulinum. It helps us in a surgical planning and helps us to understand the efficacy and the outcomes of our intervention. So we don't unfortunately have a gait analysis in our hospital, but I would encourage you all to attend some gait course, which are many occurring throughout the country now. We've had one recently in Delhi, there was one in Bangalore, and there's one coming up in Mumbai, I think, next month. And it's always good to see a gait lab. You don't need to always do gait studies for all of these children, but at least understanding how gait labs work and what are the different data that are captured by the gait labs is worthwhile to understand. So basically, when you look at the 3D gait lab, you see that these are the patients who walk through a long corridor, which is generally 6 meters long. And they have these various retroreflective markers at various points on their body, which is at fixed areas, which are the bony prominences. And then you measure basically some temporospatial parameters. You measure how the limbs are moving by looking at the various joint movements, which is the study known as kinematics. And then you study the various powers around these joints, which is known as kinetics. And then you can also sample which muscles are on or off during various phases of gait using a dynamic EMG. So if you look at the various temporospatial parameters, these are very basic data which are captured by a gait lab. We're basically looking at the duration of stance or swing phase, how much of time is spent in double support, what is the cadence, which means the number of steps those children are taking per minute, what is the step length, the stride length and the width, and what's the velocity of walking. So these are very simple parameters that are measured, but gives us a lot of understanding about how these children are performing in temporospatial terminologies. And then a more advanced thing is looking at the kinematics, where basically you have these passive markers, which are retroreflective, which are put at various points on the body. And you have cameras set up around the room, which send out infrared signals, which detect the reflection from the markers placed on the body. And then you also have kinetics, where you can have anything from 2 to 6 or even 8 force plates, which are integrated into the floor. And then you use inverse dynamics to compute joint forces, joint torques, and joint power. And this gives us a deeper understanding of how the joints are moving through space. And then, of course, you have dynamic myography. Most of these are surface electrodes, and we know they're not reliable enough, especially for deep muscles, because there's a lot of crosstalk. If you really want to do a very accurate analysis of which muscles are on or off during gait, you need to have a needle electrode, but obviously that's not suitable in young children. And normally people never use it in gait analysis, but we are using these telemetric EMG, which gives you some information from surface electrodes, and not the most reliable, but at least for superficial muscles like the vasti or the Gmax or even the calf muscles, they are reasonably reliable. So this is how a lab setup usually is. You can see that these are the infrared cameras which are set up on the side of the room. So generally there are 6 to 8 of these, and you can add as many cameras as you want. The more cameras that you add, obviously the more data you're picking up. And in addition to the infrared cameras, you also have these video cameras which are set up in the front and on the side. And these are the ones which guide you and actually doing the video recording simultaneously. So there's a lot of information you can pick up from a gait lab. In addition to all of the kinematics, kinetics, you can also simultaneously do video recordings in the coronal and sagittal planes. And this gives you a lot of information about how these patients are walking. So most labs have about 6 infrared cameras. The ones which are really well sourced out can have up to 12. You can have 2 video cameras, as we said, for the sagittal and the coronal planes. The bare minimum is to have 2 force plates at least, but these are the most expensive components of a gait lab. And there are some which can afford to have 4 or 6 force plates, and that's wonderful because you can get more kinetic data. And most gait labs have at least a 16-channel telemetric EMG. And the various systems which make this, the one that we used initially was the BTS one, but there's also available from Bicon, which is the original ones based in Oxford in the UK. And there's also many other companies which are making gait labs nowadays. They all ultimately capture the same amount of data with some minor variations. So the first step, obviously, which we don't see behind the scenes, and it's good to see this when you actually visit a gait lab, is there's a lot of time which it takes. It takes almost an hour or more sometimes to do a proper gait analysis. The first is a proper patient preparation. You have to strip the patients accordingly, maintaining their dignity and avoiding embarrassment, even in adolescent boys or girls. You want to have minimum clothing, which doesn't affect the marker placement, but at the same time, as we said, respecting their dignity and privacy. We have to have anthropometric measurements because based on all those measurements of limb lengths and body stature, the kinematics will be fed into the computer. Then the marker placements are not random. The ones who are doing it analysis know exactly where to place these markers because if there's a mistake in where you place the markers, you will get wrong information. A very typical thing mentioned in gait analysis is garbage in, garbage out. If you don't put your markers properly, obviously you'll get wrong information coming in from gait analysis. And just this patient preparation itself sometimes takes about half an hour or so. The next step is, of course, to calibrate your gait lab. And every morning you'll see the biomedical engineer walking around with a calibration wand where they're actually calibrating the lab for that particular day. And before you actually begin the gait analysis, every patient goes through a standing trial and a walking trial to check that the markers are placed properly, to check that actual proper data is being captured before you actually capture that. And that itself sometimes takes 30 minutes to an hour. And then you actually do a walking trial and you see those patients walking. And what you're doing there is all of these markers are then tracked by the infrared cameras, as you can see. And then a stick figure is then generated where you then elaborate the data and you do multiple cycles of those patients walking up and down. You can't do a single gait cycle. They have to walk multiple times because then you sit back with your computer and then you select the best cycles which can show you the data that you want to capture. This itself sometimes takes about 30 minutes to an hour. And then you can get on the computer, as you can see here, based on the markers, you can see the force plates there. You can see how the stick figure is made, and you can see that figure walking and measuring the kinematics and the kinetics. And then once all that information is gathered, the lab will then spew out all of this data. So giving you the height and weight of the patient, it will give you the various temporospatial parameters, and you have normative data on the side. And you can then compare all of those figures with the normative data in terms of distance and in terms of time. And I think the most important will be these graphs that are then giving you, if you see the top row, this is the kinematics. The next row is the kinetics. The next one is the power generation, and then the ground reaction force. And the kinematics and the kinetics are the most important. If you can read them, you'll see that there is a stance phase and a swing phase. And you can see in the hip, the hip constantly, the zero line is neutral position. This is flexion, this is extension. So you can see that throughout the gait cycle, as you go from stance into swing, as you go into stance, the hip is constantly extending. So the hip kinematics are pretty simple. All the hip does in the stance phase is to extend from about 30 degrees of flexion in the initial contact to extension in mid stance. And then all it does in the swing phase is to flex. So the hip kinematics are simple to understand. So you have a band which indicates the normative, and then you have from the data that you have captured, you select, you take the mean, and you have only two values put up there, and they're color coded, red or green or red and blue, indicating which side, the left or the right side. And from there, you'll know which side is off from the normative data. So as you can see, this is the hip kinematics. This is the knee kinematics. The knee, as you can see, is more complex. There's a double bump that occurs in the knee in stance. You can see in loading response, there's the first knee extension. Then the knee flexes. Then it extends again in mid stance, which is the most important phase of gait. And then it flexes in swing so that you have a very early peak knee swing in early swing itself of around 60 degrees. And here, just from the normative data, you can see, and the growth chart and the charts that are plotted, you can see that this patient here on one side, which is probably a hemiplegic, but is probably the knee is in constant flexion throughout swing. The knee does not extend at all during the stance phase. And during the swing phase also, there is a very delayed and attenuated peak knee flexion. So this graph tells you very clearly that here's a child who's probably in crouch. Because if you look at the ankle again, you can see that this is the normal ankle kinematics, where there's the first ankle rocker, the second ankle rocker in mid stance, and the third ankle rocker of deep plantar flexion in pre-swing. And here you can see that this patient is in dorsiflexion throughout the gait cycle, both in stance as well as in swing. So ankle dorsiflexion, knee flexion throughout the gait cycle, attenuated and delayed peak knee flexion, so a stiff knee gait, and some amount of hip flexion in swing in stance indicates that this patient mostly has a crouch knee gait. So this is how you interpret the graph of the kinematics, and if you can do that, that's great. And then for the more elaborate of knowing the kinetics and the hip power generation, you need a biomedical engineer to interpret those graphs for you. So this is a very valuable data that you can pick up sometimes which the eye cannot see or a video cannot pick up. 3D gait analysis gives you a very good analysis of the kinematics, not only around the hip, knee, and ankle, but also the pelvis, because that's one of the most difficult things to see in a gait cycle. And the transverse plane and how the pelvis moves and dips throughout the gait cycle is one of the most valuable information that you get from 3D gait analysis. So I think it's good if you all can also attend a gait course sometimes. It doesn't mean that you should be able to interpret each and everything of a gait graph, but at least a broad overview of how gait analysis is done, of how to interpret some of the kinematics is very helpful for us to understand the various abnormalities we have in cerebral palsy and to define what those gait patterns are in both hemiplegic and diplegic CP. This gives us insight into the existing pathology and helps us to formulate a treatment plan, whether this child will benefit with physiotherapy, orthosis, botulinum, or surgery. Again, remember that not all gait deviations will fit clean cut into these lovely partitions. There is always some overlap between the different types. So our minds must be flexible to understand that though we like children to fit into these neat boxes, it doesn't always happen. Most of these children can be classified into one of these different gait patterns, but there are some who may not be able to classify them. And then you can just describe the gait pattern rather than trying to forcibly fit them into one of these boxes. And a descriptive way to describe these children also is useful. So any questions? Happy to take them. Let's see all of your beautiful faces instead of just hiding.
Thank you, sir. It was a wonderful talk. So Like you said, the gait patterns in diplegic CP follow a continuum wherein it starts from a true equinus gait and then eventually progresses to a crouch gait. Does this uh, get affected by the fact if the patient is getting treated or not treated? I mean, will the pattern change if the patient has had lower limb surgeries versus if they have not had any procedures?
So, yeah, so the fact of this being actually a continuum is not actually been well described. It's just an observation that many people who are treating CP have made. It's quite possible that some children may continue to remain in jump throughout their childhood and never ever go to crouch. So it's not always true that it's a continuum, but this is a suspicion that many of us have, that they're not discrete patterns, but as children grow older, they do move from jump into crouch. And you can push these children very easily to crouch. We have seen that by wrong surgeries. Or even, Botox also can do the same, but it's less harmful than surgeries, of course. And knowing that, that's why we become so careful now with what surgeries we offer to these children, especially those with diplegia. They are the ones who are the most dangerous, because you can very, very easily push a child from a jump gait or a true equinus into a crouch gait very early on. And we know that crouch is one of the most inefficient gaits, one of the most pernicious of all the gaits that we treat.
And the other question I had was about 3D gait analysis. I mean, besides Vadia, in your private practice, how frequently do you think 3D gait analysis is required? Uh,
It's not always required. It's a good asset to have. So if there is a doubt of what is the likely treatment that this child needs, and especially when it comes to the pelvis, there are some children who are very complex to make the decision, especially about the pelvis. Is the pelvis tilted in front? Is it tilted behind? What are the pelvic rotation in stance and swing? What is the amount of pelvic dip that is happening? So the sagittal patterns are not difficult to pick up if you do a good video analysis. So I think doing a good video and slow motion especially gives you a good amount of information of the sagittal gait patterns. That's one of the easiest to find with video. The coronal is not so easy, and the transverse plane is the most difficult, because if you look at the transverse plane, you have to get on top of the patient to actually see the patient from up down, and you can't do that obviously, and that's where 3D gait analysis really helps. So I don't think it is essential for many of our decision makings, but it's good to know because it gives us a better understanding of gait. It helps us to, when we do the video analysis and we have a backup of how a 3D gait lab works and what are the data that you can capture from there, it helps us to understand our video analysis a little better. So definitely when we had the 3D gait lab in Kokila Bend, it helped me a lot, because now even if I don't need a 3D analysis for most of these patients, because my mind is now tuned that having had the gait lab, what are the kinematics that we're trying to pick up in these children with a video analysis. So that's why I think it's always good for us to visit a gait lab to try and understand how those gait graphs work. And even if you don't want to get into things like kinetics and EMGs, at least understanding the kinematics of the limb in the sagittal, coronal, and transverse planes, I think is very useful for our understanding of CP.
Alric, taking forward your point about studying the transverse plane at the pelvis. Okay, so how do you especially in hemiplegics or asymmetric dies, we often see these patients walking with a pelvic retraction on one side. So how do you factor in that information in your decision making? What does SCMLS correcting the torsional profile of the femur or tibia, does it improve the rotation at the pelvis as well? How do you factor in that information when you are planning a surgery in these children?
Yeah, so definitely a lever arm dysfunction will affect the transverse plane. And we know that the gait analysis can really pick that up, because transverse planes are the most difficult to assess. And unfortunately, most of our lever arm dysfunctions are happening in the transverse plane. They rarely happen, of course, crouch when we talk of hip and knee flexors in the sagittal plane, but almost every other one, whether it's the femoral rotation, tibial rotation, or the foot, are all in the transverse plane. And this is where 3D analysis helps you to pick that up. And definitely, if you alter the lever arms and you do that correction of the lever arms, that will reflect on your 3D analysis as well. Again, pelvic retraction in the sagittal plane is a useful information, because that tells you about your hamstring length. We know that if you have uh, anterior pelvic tilt versus a posterior pelvic tilt. An anterior pelvic tilt doesn't really mean that the hamstrings are tight. It could just well mean that the popliteal angle appears to be tight because the pelvis is tilted in front, but really when you assess them, the hamstring length is normal versus a retracted pelvis. When you have a posterior retracted pelvis, that almost always indicates that the hamstrings are tight. And that's the reason why only if we have a retracted pelvis, sometimes do we recommend the hamstring surgeries for these children. Because most of the times we have a protracted pelvis with an anterior pelvic tilt, and doing hamstring surgeries here distally is never a good idea because it weakens the hamstrings proximally. And we always think of the hamstrings as knee flexors, but actually 50% of the hip extensor power comes from the hamstrings. So we keep forgetting that the hamstrings are hip extensors very powerfully, aiding the gluteus maximus. So we keep focusing on the hamstrings as the knee, and they are thinking that they cause knee flexion and knee flexion deformities, but we forget the effect that they have on the hip. So again, understand the pelvic retraction or protraction on the 3D analysis, which is a coronal plane deformity, picked up very easily and nicely on the gait analysis, will tell you about, and couple that with your physical examination. So remember that when you're using gait analysis, it is one of the things in the armamentarium. We are not only going to base our decisions based on that. It's a combination of our diagnostic matrix that we have used. It's a very detailed clinical examination. It's a video gait analysis coupled with the 3D information that we get. So it's putting all of this together that we make that decision. What are we offering to these children? Because even gait labs can lie. If the gait lab is not well structured and you don't have, it's like an ultrasound. If the person performing the ultrasound does not know how to do it, you can very easily get a wrong interpretation of the ultrasound. So we take gait analysis with a grain of salt, and we always combine that information with our physical examination, with the visual gait analysis, and with the video gait analysis as well. So I think, if any of you all have attended gait courses, it's great. If you haven't, I think we should. Don't think that, oh, in my life, I'm never ever going to own a gait lab. I'm never going to work in a hospital which has a gait lab. That's not the point. The point is that it helps us to understand cerebral palsy a little better. It helps us to understand normal gait. It helps us to understand kinematics. It helps us to understand abnormal and pathological gait. It just makes us better clinicians. So I would encourage all of you, if you haven't attended a gait course, we're very lucky that this year itself we have had 3 courses, 2 already done, 1 coming up. And if it's in Mumbai, it'll be great to attend that. So whenever you get a chance, we have now at least these 3 centers which are doing gait courses on a regular basis. I think it's worthwhile to attend any one of them because it just improves our understanding of normal and abnormal gait. Good. No other questions? We'll wind up.
Looks like.
Great. Thanks a lot.
Thank you. Bye. Thank you, everyone. Bye-bye.
Bye-bye.